the Center for Interdisciplinary Trauma Research at AUT. And we do try to be interdisciplinary, as our name applies. So it's just really wonderful when we get a chance to spread our wings and to hear and learn from people from across different disciplines. And we're just so thrilled that you're willing to join us today. So thank you. So to begin today, I think if we could, would someone like to start with the karakia? Does someone, sorry, I didn't plan this ahead of time. Chris, lovely. I see you went off mute.
All right then, Jane. Okay.
Yeah.
Yeah. Kia tau te rangi Māori o te rangi e tū iho nei, o papa tuānuku e tākoto nei, o te taio e awhi nei, ki ronga i a tātou. Tihei mauri ora.
Kia ora, Chris. Thank you very much for that. Appreciate it. And I think because we are a small group, I think we have the opportunity to go around and introduce ourselves and just say who we are and maybe what brings us to the session today. So kia ora, everybody. I'm Ko Jane Koziel-McLean, Toko Ingoa, and I'm a professor of nursing and director of the CITR. And this is a Chicago accent. And I've been in New Zealand 20 years. So I'll pass the rako to Chris. Chris, thank you again.
Good morning, kia ora koutou katoa. I'm Chris and I'm sitting down here near Raglan, and I work as a research officer alongside Jane Koziel-McLean, which is an absolute pleasure and delight, working on the evaluation for the Violence Intervention Program. And I'll pass the rako to Shamala.
Thank you, Chris. Kia ora koutou katoa, everyone. I'm Shamala Nadraja. I'm a senior research fellow here at the University of Otago, and I've worked with Jane and her team now for a number of years. Learned so much about violence prevention through those research programs. And thank you very much, Jane, for hosting for CITR's invitation and to host Bianca's seminar today. I also worked with Dr. Jim Ross over a number of years in the broad area of mental health and services within small rural areas. And in particular, we have an interest in, anxiety, depression, common mental disorders. So Jim will could talk a little bit more when he introduces himself and later in the discussion. So it's a real pleasure to be here today and to welcome Bianca and to have you all join us for this summer student presentation. Thank you. And I'll pass the rako on to Claire.
Kia ora Shamala, kia ora koutou. Ko wai au, ko maua te maunga, ko tauranga te moana, no tauranga hoki aho. So I'm a research fellow in the Centre for Interdisciplinary Trauma Research, working alongside the team. I had the privilege of hearing Bianca and Jim speak at the recent GP conference in Christchurch. So yeah, looking forward to the talk today and learning more about the potential of HIPs and rolling out in the sector. So good, I'll pass it on to Michelle.
Morena, ko Michelle Yeoman Toko Ingoa. I coordinate the postgraduate addictions program. And I was really keen to come along to this discussion because we often get HIP practitioners complete our program. Students complete our program to get their DAPANS registration, which is the registrable body for addictions clinicians in New Zealand. So really keen to hear specifically, Bianca, about working in adapting that role because it is such a dynamic role. We all were also recently at Christchurch at that beautiful conference centre with our National Addictions Conference, Cutting Edge. So that was just in September. It must be the time for conferences, I think. Yes. So really looking forward to hearing your presentation. And handing it over to Susan.
Oh, Kia ora i te whānau, ko Susan Krill-Aho. I'm a professor of midwifery at AUT as well. I've come to this because I run the postgraduate course in perinatal mental health here at AUT. And I think addictions is one of the areas that we're not covering very well, and yet it's on the increase amongst our pregnant population. So very interested to hear this from a public health perspective as well.
And Susan will pass to Jim.
Oh, yeah, there we are. Sorry, I missed the
okay.
top
No worries.
Kia ora koutou, ko Jim Ross tōku ingoa. No tāmingi me kaurau hau, o te rake o te poti tōku kāinga i nei nei. E tāku te whānui hau. Tēnā koutou, tēnā tātou katoa. Yeah, so I'm a GP, and I'm very interested in, I've been interested for many years in mental health and wellness in primary care and community particularly, actually. And as Shamala said, she and I have been working on this, and we like working with students on this, and it's you know, cheap and easy source of labor compared to getting grants, and also it's great fun to work with students like Bianca, and they bring a freshness and enthusiasm, and yeah, it's as I say, great fun. So I've worked with HIPS and the other members of these teams of 3, and I've worked in practices without, and it's very apparent the differences. So that's one sort of thing that led to this project. But the other thing was the project that Shamara and I had done with another student the year before, seeing this being introduced into a particular community and noticing some of the things that happened. So this led to Bianca's project, which I'll be very pleased to hear the latest version of our talk, or your talk, Bianca. So I'll let me see who hasn't spoken. I will pass to Te Wai.
Tēnā koutou katoa, tēnei tumahi atu kia koutou I tēnei ata. Ko Te Wai Barbara Nasa tōku ingoa, he reo no Waikato Tainui, Ngāti Paua me Ngāti Maniapoto. Kia ora koutou, I'm Te Wai. I am based in Kaiawa on the Firth of Thames. For almost 6 years, I was a research officer under CITR, and I've just recently moved to the School of Public Health and Interdisciplinary Studies. I am now a lecturer in Māori health and sit on a few researchers as well. And I have just recently submitted my PhD for examination, which looks at rangatahi engagement in health services and how we can bridge those gaps and create positive engagement for our young people to engage with our services, but also have a positive experience and continue to seek the support that they require. Yeah, so I specialise in rangatahi health and Māori health, and the kaupapa that I'm quite passionate about as well. So lovely to meet you all, and I will pass it over to Elizabeth.
Tēnā koutou katoa, ko Elizabeth Apple, tōku inu. Inaine I noho au ki whanganui a Tara I mahi o te waka, te heringa waka, te kura kawanatanga. So I'm an adjunct at Victoria University, and I've been working with Claire on some of her projects, and she invited me to this little hui a few minutes ago.
Great.
Kia ora koutou. I can't see anybody who's...
I think Lisa is the last.
I might have missed Lisa.
Yep.
Tēnā koutou katoa, morena everyone, ko ingarangi ko Ha moa te whakapaparanga mai, ko whanganui, ko Tāmaki Makaurau, te whenua tupu, ko Tāmaki Makaurau te kāinga, he projects o AUT University. Good morning, I'm Lisa Mullions, and I'm involved in projects with the School of Clinical Sciences, but specifically supporting the CITR research rupu and the amazing project that is Atawhai, the work of Atawhai, which is the improving the responsiveness in the primary healthcare sector to family violence. So thank you, everyone. I'll be in the background today. Looking forward to this talk.
Thank you, Lisa. Thanks, everybody. Great to have you here. I think we were really interested in this talk. And as we were looking at primary care and prevention, a lot of people started talking about hips. And some of us were like, okay, what does this have to do with anything? And so we started learning, and it was, so we're really excited to hear in family violence, clearly there's a lot of intersection with addiction, mental health, physical, and violence to coercive control, and all aspects of violence. And whenever there's something new that's being tried in the sector in primary care, it's, you know, quite important that we all kind of learn about it and say, you know, what's happening, what's going on, what can we take from this, and how can we support evidence-based effective intervention. So just really, really thrilled to be able to have some learning today. So I'm going to hand it to Shamala, who's just going to introduce Bianca quickly, and then we'll be able to hear from Bianca and Jim and others, and hopefully have a really robust conversation about it, about hips.
Thank you very much, Jane. So yes, it gives me great pleasure to introduce Bianca Crichton today to present. She has presented a number of times already. She's presented up to our team here and at a couple of conferences. And this is quite an achievement, Bianca, for a summer studentship. And I know you're going to be presenting to another conference next month. So the actual topic of hips was something I think that Bianca actually was very keen to do after we presented her with a whole lot of literature to go through. So without further ado, I will hand over to you now, Bianca, and we're looking forward to your presentation. Thank you.
Kia ora. Yeah, really, really lovely to be here. Yeah, I guess I'll start. O ko tōpiri te maunga, ko Waikato te awa, ko tainui te iwi, ko Bianca toku ingoa. It's really, really lovely to have the opportunity to present to you guys today. I have to say I was quite a bit nervous. Like I'm really, I guess, I'm really admire all the mahi that you guys do. And it's really kind of cool to be able to have a kōrero about that and with what I was doing as well. And yeah, I guess also, you know, some of you might, Claire, you're saying you saw our presentation to the conference in Christchurch, but it's kind of cool that we can have, I guess, a longer opportunity to kind of talk about it, because condensing everything into a very short amount of time was pretty tricky. We did another conference where we had to do, I think it was like a 3-minute video or something, which was a bit of a challenge. But yeah, I guess maybe I'll start screen sharing. It's probably the best way of doing it. This one here. Good to start. Oh yeah, I should probably say, so I am a 3rd year student in public health. And so I have just kind of handed in my last assignment for my degree, and working on my last couple of exams as well. And then not really sure where I'm going to go from there, but we'll kind of figure it out. Yeah, I've really enjoyed learning. I guess throughout my degree, I think it's been a particular interest of mine has been like mental health as well. So when Jim and Shamala kind of gave me a whole lot of options, I was like, oh, I mean, they're all mental health related, but this was one that I thought was kind of super interesting because it's very topical at the moment. And yeah, I guess I'll just start. So this is our kind of we've had a few different titles, but yeah, evaluating health improvement practitioners in small practices and their colleagues as well. And so, there we go. Yeah, just acknowledgements, like huge thank you to Jim and Shamala. They were like, I literally couldn't have done it without them. It was a very amazing process, kind of working collaboratively with them. All the participants are like, so my research project was over December to like February, so it's kind of over Christmas, New Year, which is like a pretty tricky time. So really grateful for people who gave me their time for the interviews, and then yeah, for the financial assistance as well, because obviously that was pretty great. So I guess it sounds like a lot of you are familiar with Access and Choice. Well, it's got a few different names. There's like the Integrated Primary Mental Health and Addiction Service, there's Access and Choice. I think now in Well South, which is like the Southland PH or the Otago Southland PHO, it's called Toku Oranga. And I think this first kind of, the start of it was called Te Tumu Waiora. So there's kind of like a few different names that float around. But we're just, throughout this, I think we've referred to it as Access and Choice. So a bit of background, I guess you're probably all like pretty familiar with this kind of, this report and I guess the findings from it and stuff, but just talking about how, you know, we have a really high prevalence of like mental health and addiction in New Zealand. And they've kind of noted here like a specific lack of services for those with mild and moderate mental health issues. And there's this quote from the report, like, need to improve access to and choice of services for the missing middle. And I guess maybe, you know, Access and Choice kind of came out from this report, like just thinking about ways of kind of, I guess, trying to do the primary care sort of side of stuff. Why is this not working? There we go. So Access and Choice is kind of this approach to wellbeing within general practice where you have the health improvement practitioner and the health coach who will be like embedded in the general practice ideally. And the health improvement practitioner works within like a focused ACT model, and it's kind of, their role is to develop strategies with patients and kind of help improve. Not usually they do like mental well-being, I guess, but they kind of, a lot of them talked about how they do more than that. So it's not just like, their role isn't just counselling. They're quite specific in saying they're not counsellors, but you know, they do this kind of broader approach. And then the health coach is kind of helping patients like manage long-term conditions. So a lot of the time they were working with people with like diabetes or pre-diabetes or like high cholesterol, kind of getting them on plans and things like that. But the two kind of work together, and that was quite useful when they can kind of refer patients to each other and things like that. And then there's also a community support worker who was like the third part of this, I guess. And they were kind of supporting patients with any non-medical needs. So one of the support workers, you know, would like help arrange getting people to appointments or help them like go grocery shopping or help them like, one of them, you know, during COVID set up the vaccine passport and those sorts of things. So like all the kind of things that contribute to well-being, I guess, that's not like specifically medical. And that was kind of good when they all kind of worked all together. This is like a little poster that I found in one of the practices, which was in the reception to kind of advertise the service, I guess. So listing like a whole bunch of stuff that you can kind of, I guess, come and help. So they say, yeah, the health improvement practitioner or the health coach, and it's free. So yeah, the key features of the service were mainly like they talk quite a lot about this warm handover. So this is the idea of, you know, someone goes to their GP with some sort of, I guess, problem that they would like support with, and then the GP or the nurse could kind of walk them down within the practice, walk them down the corridor, kind of knock on the door and then introduce them. Even if the HIP had someone or the health coach had someone in their office at the time, they could still be like, oh, well, you know, I've got a space in 20 minutes. Like, do you mind waiting? And I can see you. So it's kind of like, instead of just referring off to some random person that they've never met before, trying to kind of keep that engagement up with the warm handover. The consistent embedding of Access and Choice staff was also a key feature, I guess, because, you know, then they're in the office, you can kind of do those warm handovers every day. They can kind of, the HIP and the health coach can kind of have discussions with each other and like refer patients to each other depending on the need. The presence, so that also goes to the presence of all 3 access and choice staff. So the kind of model was designed around having those 3 people, which I guess covers a lot of options for care. And having free same-day appointments was also a really key feature of, reducing that waiting time and not making people kind of be referred and have to, get a letter back in like a month or something like that. So kind of giving patients support when they needed it. Were those key kind of features. And so the program was initially developed in like larger practices, as you probably picked up from those things, and a lot of those the features aren't necessarily something that you could do in a smaller practice. So we were kind of interested in exploring this and how this works, and seeing the way that the program is working in these small and medium practices, and then kind of identifying the adaptations to the delivery, and how and the uptake of the program. And so we looked at several small and medium practices and in rural and urban settings as well. Sweet. So this is just a thing on methodology. I guess I don't need to spend too long on this, but we used case study methodology, which was quite good to kind of do quite an exploratory study and look at lots of different cases and kind of see what was happening along within them. So we based it around some key propositions. So we kind of started with these propositions and went and see, do our findings kind of reinforce them, or do they challenge them in any way? So we started with looking at like issues of scale. So as I talked about, some of those factors might not necessarily be able to be implemented in like as you get down to like smaller and smaller practices, that smaller practices will make different adaptations to the model depending on their context, that these adaptations will be consequential, and also looking at like equity issues. And so looking at practices who do have the service and then practices who don't, because if you're enrolled in a practice who doesn't have the access and choice service, you don't have access to any of those roles, I guess. So we're thinking that's quite a big equity issue. So these are kind of this is like my real fancy diagram of the case studies. So we've got the different shapes, like the star, the circle, the square, and the triangle, the 4 different cases. And they had a kind of clusters of practices within them. So you've got varying from like 4 practices to like that 1 practice there. The like dots are each of the health, the HIP, the health coach, and the community support worker, and the kind of lines are like the links between them. So you can see quite a lot they were like shared between practices, especially in that circle one, which I'll talk a little bit more about. And so it was quite good to kind of compare one practice which pretty much had the whole full model in this triangle versus one which was definitely very spread out. And I did 24 interviews with the HIPs, the health coaches, and then like practice staff and some community informants as well. So trying to get like a big, I guess, talk to a wide range of people, but we didn't talk to patients. So the results was pretty, everyone was pretty, I guess, supportive of the service. The most people, pretty much everyone I talked to was really thought it was really great. And the issues that they kind of raised were more to do with the implementation rather than the actual service that was provided. And practice staff especially thought that it was, they really liked it. They thought it filled gaps in patient care, I guess, especially because I was interviewing kind of around the time of COVID as well. So like lots of things, there's a lot of pressure on GP practices. And so this kind of program was able to take a bit of pressure off there. There was like an observational decrease in referrals to the brief intervention service, and quotes of making the whole system more efficient, which was pretty awesome to see. In some places they kind of got rid of the waiting time for the intervention service in that area, which was pretty cool. And then one GP noted that they now almost never prescribe antidepressants because they could just refer people to the HIP, and then the HIP would kind of, I guess, take that on board and see if they needed them or not. But so that was kind of good having this, like, someone described it as like a safety net, like for their patients. I thought this would probably be pretty interesting for this discussion. So one of the people I interviewed was like a women's health nurse, And so she was really positive about the program, and she was talking about, you know, she commonly sees people with kind of sexual health concerns, dietary issues, breakups, financial worries, those sorts of things. And she thought the program was really like helpful for her. So she kind of, yeah, just kept raving about, especially like the hip and the health coach. And when I talked about warm handovers, she kind of said that she used them quite a bit, and it was really good to kind of give support to the patients kind of as they needed them. And then, yeah, in particular, she mentioned the benefits for youth aged 14 to 18. So she said that, you know, because of COVID and stuff, she was seeing quite a lot of like anxiety within youth and people coming in. And so she kind of was saying, you know, it's really great that she could kind of give them somewhere to go with that. So yeah, I thought that was interesting. So this might seem a little bit familiar for some people, but I thought this is also quite a good, I guess, a good case study of, you know, looking at it in really small practices that are kind of spread out. So this one here, we've got these 4 practices, and they're all probably like 40-minute drive, an hour drive away from each other. So they're quite dispersed. And the sharing arrangement was pretty much, you'd go kind of to one practice every day. The community support worker worked 2 days a week, I think, for all, like, and then that would cover all 4 of the practices. So it was pretty like spread out, I guess. And this one was the one that raised the most, I guess, people talking about like the difficulty building relationships, because obviously if you're not there to kind of talk to people all the time, like it can be pretty tricky coming in once a week. You know, by the time you've been in there 10 times, you've been there 10 weeks, you've been working for 10 weeks. So it kind of takes a long time to establish that rapport, I guess. Like spatial issues, because smaller practices don't have necessarily like just rooms lying around. They're all, you know, very valuable spaces. So kind of having to change depending on which one was free that day. So you couldn't kind of carry around all your information and things like that. You had to carry around all your information. You couldn't like put it up in the rooms. And then the warm handovers, because they were only usually there once a day, or once a week, the warm handovers weren't usually possible. So they'd kind of have to do workarounds, like I guess like booking them up and things like that. And a few of the staff were kind of talking about the sustainability of that sort of arrangement, especially with like the driving times, having to kind of work so much to build those rapports. One of the interviewees was talking about how this lends itself to burnout. Yeah, and I'm not sure what the situation is now, because obviously this was last summer, but that kind of did look like something that definitely needed to be addressed. So some of the workarounds that we kind of identified, there was, I guess half of my report we kind of talked about workarounds, and I was thinking about maybe sharing all of them with you, but I thought maybe we were best to kind of just keep it a little bit shorter, and we'll show. So obviously greater use of pre-booked appointments, and then kind of, so that was one that they did, especially when they were like shared and not there every day. There was one case where 2 practices in the same town shared a hit. So when they booked the same day appointment, so when one hit was in, I guess, practice 2, practice 1 could ring them up and say, do you have any spaces today? They'd be like, okay, yeah, in 20 minutes. And so the patient would walk to the next practice. And that was a way, I guess, of still getting that same day things. Doing semi-warm handovers. So just instead of meeting face to face, but doing a phone call, I guess at least you're still meeting a person. The team meeting, so that was kind of noted as quite an important part of the program, like obviously sharing them all together and like discussing ideas. And so doing these either by Zoom or if they're like driving through different areas was a good workaround. That's meant to say evening clinics. But that was also seen as a way of like increasing access, which is cool. And then the hip and health coach alternating days. So, you know, Monday to Tuesday, and then the health coach doing Wednesday to Friday. So then at least you're getting that coverage throughout the week, but you're just not getting them there at the same time. Sweet. So we also kind of one of the questions, or a couple of the questions that we would ask would be, you know, how do you think the service works for Māori and Pacific clients? Because obviously that's a really important part of equity. And so there were kind of mixed responses with this. So with the PHO, when they kind of are talking about this, the service, it's really cool. They're saying that Māori and Pacific people are using the services at a higher rate per population than other ethnicities. And so that was kind of what we were hearing. But when I was interviewing people, there were people who were saying that it was the services were being underutilized by Māori and Pacific clients. And I guess the service are only available for those who are enrolled and accessing practices. And so there were kind of a few challenges with promoting the service to big community groups, because if you've got quite a few practices, I guess I'll talk about this a bit later, but if you've got lots of practices in the community and only a couple of them have the service, you can't really promote it as a community service. And so then the only people who really hear about it are people who are accessing the GP services. And so that was kind of an issue there, I guess. And then, so the structure of the service was also noted. So obviously the availability of free and same day appointments and having this kind of broader, like holistic approach was seen as really encouraging for Māori and Pacific clients. But there was some hesitancy kind of noted with especially the HIP kind of structure, or like the initial one as well, like being quite inflexible. They've got 30 minutes and they have quite a few kind of questions, like standardized questions that they have to go through and ask. And so they kind of felt that they had to be a bit rushed. And some of the HIPs said that they kind of they're meant to take 30 minutes, but some of them said that they took a lot longer, but they weren't really supposed to do that. But yeah, they just did it anyway, I guess. But that was just like interesting to note, because I guess the program or the Focus Act stuff is something that does come from America and things. So that was kind of noted as like maybe kind of putting that into the New Zealand context might not, the structure might have a few tensions, I guess. And then so I guess the extent to which the practitioners like actively, I guess, went out and tried to broadcast the service to Māori and Pacific clients and kind of encourage them to come. A lot of that was, I mean, a lot of the workarounds were dependent on the practitioners anyway, but this was kind of one of them. And so there were a few who were like really good at kind of trying to go out and talk to like the local Pacifica church groups and that sort of thing, and local runanga. But yeah, so it kind of depended. But it was cool to see that there were definitely some individuals putting mahi into that space, and that was kind of, you know, setting that example. And so this was, again, going back to this this example that I talked about before, and looking at how this the effect on like the whole of the community. So there's within this place here, and within this example, we had 3 small rural towns who have, you know, they have one practice, and they, by putting in the service, they kind of received this local mental health service for the first time, and they thought that was really awesome for them, because instead of usually mental health services go to like the big kind of town centre and you have to travel in, but actually having it there, even if it's only a few days a week, that still was kind of more than what they were having. And so that was like a really positive thing. And then you could kind of see, it was quite interesting that it was within the same case study, I guess, or the same case, that one of them was like this big town which had lots of practices in it, but only one of them had the service when I was interviewing them. And so we could kind of, I talked to a community, one of the community leaders for the mental health, I guess like group alliance thingy in that town. And she was saying that, you know, although she was kind of really excited about the program, she kind of couldn't really assess the effects that it was having on the community because it was only in one practice. And she kind of what seemed, she was also noting, you know, the issues of, I guess, promoting it as a community service when it's not actually a community service. And so the previous summer studentship that was done, interview also in the previous summer student also interviewed her, and she was really, really passionate about the service and thought that it was really great. And then when I kind of interviewed her, she seemed like a little bit less excited. I guess she was a bit more kind of, you know, well, like people aren't wanting to take it up. And so it was kind of interesting to see that change, I guess. But yeah, and so I did talk to a couple of the GPs within that town who didn't want to get the practice, or one of them was getting it kind of reluctantly and seeing how it was going, and then another one didn't want to get it. And the main things they were talking about was kind of the business side of things, and how having to find the space and having to have someone who is meant to be part of their team, but they're not in their kind of payroll and that sort of stuff. And there were a few things around that. So that was interesting, I guess, getting that different perspective. And then, yeah, I thought I'll finish up soon so that we can have time for a discussion. But overall, the service was really appreciated by the people. I've said IPMHA, but I'll talk about that later. But yeah, by the people who I interviewed. And yeah, like I said, most of the things that people said about it that were like the challenges, I guess, were more related to actually the implementation of it rather than the service itself on a whole. And so, yeah, when we're looking at kind of rolling out to small areas and practices, I guess some of these things are just things that we have to consider and kind of keep developing those workarounds. Obviously, the people who are actually, you know, doing that mahi every day, they're kind of constantly refining it. So if I went and did this project now, I'm sure, you know, there'd be another amazing list of stuff that they've done. But yeah, so yeah, we did find that patients who were not enrolled within a practice who has the service were disadvantaged. I did talk to one practice manager, and I asked her explicitly about this, and she was like, yeah, I do feel like they're kind of missing out just because, I guess, yeah, they don't have that sort of the same level of access, same level of care. And then, so I was talking a little about the name, so like access and choice and the integrated primary mental health and addiction service. So although when I was doing the study, they called this particular service access and choice, I guess if we were looking at like the broader, like the national plan, it's actually called, it's like this one here, the IPMHA, this like purple one, I guess. And the idea is access and choices combines all four of these. So it has the IPMHA, it also has kaupapa Māori services, Pacific services, and youth services. But I guess the rollout of IPMHA has kind of been the most rolled out, and the rollout of kaupapa Māori and Pacific and youth services is still kind of, I think it's still quite slow, maybe because of COVID and those sorts of things. I didn't look super into those because I was mainly focused on IPMHA, but it was kind of interesting to see that it's meant to be, you know, part of, I guess, a broader thing. And I guess some of the challenges that we identified with Māori and Pacific clients, if you had those other services there as well, that would be a lot better to, I guess, give a more holistic, I guess, care. But yeah, that's my presentation, the formal part, I guess. Sorry if I was speaking really, really fast. But yeah, should I stop sharing?
That was great. Thank you, Bianca.
No worries.
And well done. Just a really wonderful presentation. And I wonder, I'm sure we have lots of conversation. Anyone have a question that they want to, or a comment that they want to begin with?
I suppose the first thing I wanted to say was well done, and I can't believe that you did that on a summer scholarship.
I know.
Taking my breath away. I wish some of my doctoral students did that much work in such a period of time. So that's what I wanted to say. I suppose that I'm coming from my perspective as a professor of midwifery. One of the things that comes up in my work, and also I did 25 years in rural area as a midwife, is the people in the middle. I can't remember the term you called it, people who've got in the middle area that kind of drop through the net. So when people had severe psychiatric issues, it was a no-brainer. There was a definite way of referral and getting things sorted out. and people who have very minor can often be sorted out in relationships within community. But it was that middle group that if we don't resolve it, and there really is a complete paucity of referral strategies. So that's everything from addictions, from violence in the home and mental health issues. It's really difficult. We had a neighbour recently, just to give an example about how your work is so important. We all could see the signs that she'd stopped taking her manic depressive drugs. We could not get mental health services involved until she went into complete crisis and we had to call the police. And it was like, what a shame. It did not need to be that traumatic. And now she's an inpatient. It could have been a much more community-based approach. So I commend what you're doing. But my question is, was there anything around perinatal mental health, which is a really big hole in the services? And we know that we have a suicide rate amongst pregnant women that's 7 times more than most European countries. So we really do have an issue in Aotearoa and New Zealand, sadly.
There wasn't anything like explicitly mentioned about perinatal mental health, but I see what you're saying about, you know, the lack of services for those people and how it could be, you know, this could be potentially one option of, I guess, extending that, because it does seem pretty crazy that, you know, you have to wait until you're really, really severe until you get kind of that extra support. So definitely, I think things like this could be definitely used. But no, not in my study. We didn't have like explicit talks about that, I guess.
Thank you. It's all about finding what the gaps are so we can go and address them. Thank you, Bianca.
Hi, Bianca.
Kia ora.
Awesome presentation. Whereabouts from the Waikato are you from?
Well, actually, it's kind of interesting. So my whānau is up in Waikato, but I've only met them like once recently in Te Awamutu. So it's kind of beginning that process of reconnection.
Oh, right.
Yeah, so I grew up in Tahuna in Queenstown.
Okay. Quite a different spot.
Yeah, yeah.
Cool. Hey, I'm interested. It's funny. I have an enrolled nurse and a social work background, so I'm always curious as to the disciplines that are being employed as HIPs, HCs, and the health workers. Can you just kind of give an indication of what disciplines are in those different roles?
Yeah. So the HIPs were they had to be registered. I think it was registered mental health workers, the HIPs, but the health coaches, there was a few who I interviewed who were like recent graduates in kind of nutrition or like social science. That was like quite a broad role, I think, but the HIPs were definitely the ones who kind of had the most clinical experience, I guess. And then the community support workers were usually, like support workers, and they'd kind of, I guess, transitioned into this role other than the other support worker roles usually.
Could I add to that a little bit? I think there are quite a lot of occupational therapists who are taking up the HIP role, and it works really, really well for them.
Wow.
Bianca and I had a really interesting discussion with one of the trainers of HIPs from Te Po, and at conference, that GP conference, we had a really interesting conversation. She was saying that, you know, OTs just fall into the model really well.
Yeah.
Clinical psychologists, there's a few of them, and they argue the point and are not very susceptible to the training because they come from a very different background, from a 50-minute, you know, interaction, not a 30-minute interaction, not brief intervention, and so they take a lot of convincing. So it's extending out to other roles. There are nurses, there are, what else? I'm just trying to remember now.
Social workers?
Social workers, probably, yeah. If they were sort of clinically focused social workers, I'm sure there are those as well.
Yeah.
Counselors are just starting to come in, again, coming from a different sort of mindset, and also different registration sort of setup as well. So
yeah,
that it was, you know, you have to be a registered a registered medical, registered, you know, under the HPCA.
Yep.
That was a criterion. And the health coaches are kind of interesting because there is a sort of Australasian professional body of health coaches which has emerged, and they are quite annoyed about this because they have a training program, they have the whole professional setup, and meanwhile what's happening is that from their point of view, kind of amateur health coaches are coming in and doing this. But of course the whole program is around massive rollout, you know. And even the manager of the program in the Southern region said that the least well-developed role is the support workers role, and probably criteria, I think probably just people who have some kind of community experience or a variety of about.
And I guess what I'm thinking of is that tension around often professional disciplines and how they perceive, as you say, you know, like support workers who perhaps don't have the same level of, you know, clinical education, I guess. And the other one I'm thinking of, Michelle, I'm kind of looking your way because I'm thinking of like the peer support workers in the alcohol and drug sector. It's a little bit similar, isn't it? And I guess the other thing I'm just thinking is that those, whoever they are, would really need good support and supervision in those roles.
Yeah, peer support and PSWs are usually level 4, so they usually have some training or qualification in level 4.
Right.
And that's the whole, I guess, from an addictions perspective, one of the, I guess, purposes and roles of our program is that we can add that kind of additional professional training and expertise. So our program is endorsed by DAPANS, and people who complete it come out with registration, so they can get their registration through that pathway. And saying that, most of the HIP practitioners who come into our program are usually social workers and counsellors who, because often, I know it's a bit different in Auckland than it is in the rest of the country, often HIP roles want that DAPANS registration. They see alcohol and drugs or addiction issues as being a significant need in that role. So but it's really, I mean, addictions in general in New Zealand are just as most areas of health are in such we're finding it so difficult to recruit and retain staff across the country at the moment. And so actually the peer workforce is becoming quite significantly large. I don't know if they feature in those HIP roles though, but if they did, they would be more in that CSW type role. And it's interesting because it points to the whole kind of issue, I guess, being trained as a nurse myself, it points to the whole issue of, you know, what kinds of qualifications do people need to be considered sort of clinicians, or kaimahi, or taking that kind of case worker, caseload type role. And I think that these HIP roles have kind of highlighted that. But I know in Auckland, when the HIP roles first came out, CADS lost a lot of practitioners to the HIP roles. So services that were already struggling to recruit and retain staff then lost their staff to the HIP roles. So for the addiction services, it was actually quite problematic. But of course, we fully support the HIP roles, but it was just another challenge for the addiction sector. So quite interesting, all of the different aspects of it.
That's a very well-known unintended consequence in New Zealand when new programs start. The very best practitioners from the program that was there go into those roles, and they leave that gap. And
absolutely, and they do tend to attract really experienced clinicians. In my experience, every HIP practitioner I've come across is extremely good at what they do. So experience is one thing, but being really good at your job is another thing, right? And they generally are really incredible people. So they have there's obviously something quite attractive about the role. Maybe it's the autonomy. Of course, the 30 minutes I don't think works well for anyone. I've never heard anyone appreciate that. But yeah, the caliber of practitioners is very, very high from my experience.
That's great.
Yeah.
That's great to hear. Yeah.
Yeah, it is.
And Bianca, I'm just wondering, you know, with these experienced practitioners, are they feeling supported, and do they have what they need to be, you know, to be a career choice for them that works?
I think there was mention they do have like kind of networks of health improvement practitioners and also of health coaches who they could kind of like talk about different ideas and see what other people were doing. That was mentioned a couple of times, which did seem to be, I guess, obviously that helps with the that kind of side of things. I think the HITs who I did talk to, most of them really enjoyed their role. The one who was kind of shared across all those practices thought that there was not that much support and that was pretty tricky. And so I guess it does depend on like how many, I guess, the extra kind of things that they're having to do, and a lot of the time making those workarounds and things, a lot of them were like, yeah, that's really cool, but sometimes that support to kind of make those workarounds was, yeah, she kind of identified as, you know, maybe a bit of a challenge. So I guess it kind of depended, but they did talk about having this like network, which was really cool to see.
Wow.
It'd be great to, in the longer term, I'm thinking sort of 5 to 10 years, the professional development and scope for development for these practitioners who are obviously really competent and probably seek to be stimulated in evolving ways as they progress in the roles, that it might be something worth considering. I mean, I'm sure it's probably already considered, but that there would be some development within that role, whether it be that, you know, maybe there's scope that they do the 30 minutes, but then they also have a timetable or space in their working week to do the more, you know, kind of intensive work, the 1 hour work. So they do both the brief interventions and the longer term. It'd be a really interesting project to actually scope do a needs analysis of what they would see as being professional development in that longer term, so that you did retain those incredible people that are already there. Yeah, because that would be, you know, that might involve workforce development, but I imagine just within the role, the day-to-day role itself, that brief intervention is really interesting and stimulating, but often people will, like in any job, will seek something else as well as that over time.
Lots of options for future summer students, eh, Shyamalan Jim? You'll be thinking, I can just imagine. We look forward to...
I'm writing down Michelle's idea. But actually we did want to do one this year, trying to start to investigate the Māori and Pacific side.
That's what I wanted.
You know, that takes a lot of work to set up. So we haven't gone down that path, but just this interesting conversation that Bianca and I had with the trainer. She said that because our impression is that very little effort has actually been put into those other pillars, the Māori Pacific and rangatahi pillars, which are supposed to go alongside it. There was a scoping exercise on the Māori side of what do Māori want. It doesn't seem to integrate with this, and so apparently what's happened on the ground, according to the trainer, is that Māori providers have seen this in operation, have seen the IPMHA mainstream one in operation in other institutions, and they've said, oh, we should have that. And so they've sent along people to be trained as HITs. And it has been, you know, it has been a little bit difficult because it is hard to fit this with Māori models of health. But apparently there have been some places where there has been a kind of integration that's just sort of happened organically, which again, would be super interesting to know more about, and probably more happening in your part of the world than ours.
Yeah.
Because the reason that we couldn't really access that was that I think at the time there were only two supposedly Māori institutions that were in the program, and yeah, so they didn't happen to be in our case studies. But the sort of, you know, I've forgotten the name of it, but that sort of East Coast programs using Purako, and you'll know what I'm talking about. Some of you. That was kind of being organically brought in. Do you know Bianca?
Oh, sorry, I was just waving to Susan. She's just sent a message in the chat.
Oh yes, I see.
Yeah, Perinatal is being employed a lot in kaupapa Māori addiction services at the moment. And I don't know any HIP practitioners working in kaupapa Māori services, but I do know Māori HIP practitioners who are, again, really incredible, but they're working within that Western framework, you know, just the time frame in itself is just, but I wondered, yeah, like it's about bringing in Māori concepts, but also I wondered if another research project around, you know, HIP and a whānau order type framework, how that might work. It's really exciting space, you know, because there's so much scope for development and evolving. And I think that the most important thing is that that these roles do develop and evolve and respond to the people that need it the most. Yeah, but it's really awesome idea.
So when you say the trainer, Jim, you're talking about Te Po?
Yes.
Oh, yeah. Okay. So it's Te Po with primary care.
Well, Te Po has the contract, I guess, for training contract. HIPs and and yeah, that was another interesting thing that she said. The PHOs actually chose the people who were going to be HIPs, and then they sent them for the training.
Yeah.
So the Te Po trainer wasn't necessarily convinced that they were all ideal. So there was not a particularly good matching there necessarily.
Yeah, that's an important process.
And the other interesting institutional things about this, like the in different PHOs it works differently, but in our PHO the HIPs were employed by the PHO, and the health coaches and the support workers were contracted from other institutions, like you know, the sort of mental health support type institutions. So that was another interesting potential tension that was in the system.
I think one of the health coach was saying, because yeah, there was like lots of different ones, and you know, obviously there's a lot more I guess admin that goes into organizing that, but then also there's this whole kind of like diversity of roles that comes in, where you're getting people from lots of different, like Sport, Otago and all these other places, which she said, you know, even though there's this kind of thing, it could be good to kind of have those different roles, but I guess sorting out how to do the best way was, you know, and for practice managers kind of figuring out who was employed by who.
Yeah, I bet. Yeah.
I mean, I think that just raises so many issues of contracting, to have people going in different places reporting to different people, and it seems that creates a situation where support and resources, you know, that there are gaps and variability in how things are actually implemented, which we really don't want to have. We want people to have clear roles and clear support and resourced appropriately, as opposed to, I mean, even nurses in schools have the same thing, where some nurses work for the Te Whatu Ora and others work for the education. So it just, you know, there's got to be you know, one model that gets supported adequately, and the admin, Bianca, like you say, would be, you know, everybody creating their own, having to put in their own effort for contracting and terms of reference and everything else, and it's just creates a lot of bureaucracy that takes away from actually doing the mahi. Just
Could I
my
just make a
opinion.
quick comment that this is a typical New Zealand program, insufficiently resourced.
Yeah.
Depending on the practices to actually put substantial resource in, which has put off some of the practices, as we heard from Bianca. And with a grandiose plan that this will roll out to all practices in New Zealand, which is actually not possible. So it's never going to be equitable, because there are always going to be practices too small or unable in some way to take it, and their patients are disadvantaged systematically. It's already happening. So that was the kind of premise of our study. And what we did was deliberately make a sort of appreciative inquiry aspect to it, and look at the workarounds, and, you know, looked at all the clever things everybody was having to make up on their own, kind of on the spot, or within their program, to try and work around and make this thing work. So, you know, that's the way we do things in Aotearoa, New Zealand, unfortunately.
It's all the secrets you keep, isn't it? To keep, you know, to get your job done. And Bianca mentioned around some people working with Māori and Pacific do the sessions a bit longer, but, you know, you sort of rush the fact that through that, you know, saying it, even as reflecting that kind of secretiveness that we need to do to actually deliver our, you know, to do our work effectively.
Yeah. And I was just thinking in the area of family violence, which is what we're talking about, and sort of, you know, what the Artify project. And I guess, again, I was thinking about that whole process and how that is rolling out compared to, you know, in comparison to this kind of implementation, I guess. It's quite different again, isn't it?
Claire, you had your hand raised.
Yeah, thank you, Bianca, for your presentation. I just had a question around whether there's any kind of feedback loop from the HIPs, health coaches and support workers back to the GPs. So whether any information is being fed back to GPs so they can improve their care with the people that they're working with.
So yeah, I think definitely that was mentioned as like being quite a strength of, you know, when they have those relationships with their GPs, kind of being able to kind of, like talk to them and think, kind of devise ways as well of, I guess, reminding them and like educating them about the model, because lots of GPs weren't kind of familiar with the model as well. And I guess that when the practitioners were there, the more often they were kind of able to do that, you know, maybe not as like super formally. I don't think they was mentioning like, but, you know, being in the team meetings and kind of just talking to the GPs. One of them made a real conscious effort, one HIP made a conscious effort of like whenever a GP referred them, kind of going to the GP and like thanking them for referring and kind of talking about the patient, to kind of, I guess, encourage them and see that they were doing, you know, that by referring was quite good. So I guess, and then the challenge was then in those places where they couldn't really build that rapport with the GP. So one of the HIPs when the day that she was in the practice, the small practice was when the main GP wasn't there. So they kind of never had this opportunity to kind of meet and like discuss. So then that was a challenge by not being able to do that.
But it is built into it though that the HIPS notes are in the clinical notes, the practice's clinical notes. So that means that, you know, that there is that aspect of feedback, which is pretty useful.
Yeah, thank you.
Cool.
Yeah, well, I think our time is coming to an end. Thank you so much, Bianca. Well done. How about a big clap? You have done an amazing job for a summer student, and we just wish you all the best, I'm sure, for your public health career. And I'm sure we'll read and see more about you in the future. So that's really, really exciting. Any final questions or comments before we close? No. Okay, I'll go ahead and just have a karakia whakamutanga. And my apologies, this isn't in Ngāi Tahu dialect, so coming from Tamaki Makaurau. Unuhia, unuhia, unuhia ki te uru tapunui, kia wātea, kia mama, te nako, te tinana, te wairua, I te ara takata. Koiara e rongo whakaria ake ki runga kia tina, tina, huie tai kie. Everybody have a great week.